Welcome to All In, a straight shooting, science-based podcast about periods, fertility, and nurturing health outside of unrealistic beauty expectations. We will mostly, but not exclusively, focus on hypothalamic amenorrhea, HA, a component of the female athlete triad, and relative energy deficiency in sport.
I'm Dr. Nicola Rinaldi, scientist and lead author of the book No Period, Now What? I specialize in helping people understand how their eating, exercise, and lifestyle habits are keeping them from hormonal health and their best life. My work focuses on regaining periods, improving fertility, and breaking free of the rules of underlying diet culture.
My name is Florence Gillet. I'm a certified eating psychology coach and the founder of BeyondBodyImage.com. I specialize in mental recovery, helping people let go of toxic health beliefs to finally feel at ease in their bodies at any size.
Every 2 weeks, the All In podcast brings you real recovery stories, expert insights, and new scientific research on HA, hormonal health, and fertility, with an unmissable touch of body respect and women's empowerment.
Just a reminder that this podcast represents the opinions of the hosts and their guests. The content here should not be taken as medical advice. It is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Music by the Andy Shulman Band, available on Spotify.
Before we start in on today's fertility myth-busting episode, which I'm really excited about, I just want to remind you that I'm not a medical doctor or a medical professional. I'm sharing my observations, experience, and research as a PhD biologist based on the thousands of people I've worked with directly and indirectly, as well as the research that I've done. So please use this information to generate a discussion with your own medical doctor or other professional who is working directly with you. Thanks so much.
Hi, Nicola. How are you?
Hello. Good. It's so nice to be recording with you again. And I'm really, really excited about this episode.
Oh, me too. And I find that it's like such a lovely time for us to always have to get together at some point.
Yes.
No excuses possible. So
Right.
I'm really glad we're here together. And today, for our wonderful listeners that we thank to listen to us. So we want to talk today about fertility myths. And we're going to do a bit of myth busting.
Yep.
And
There's so many of them around
oh,
HA, and
God.
that I keep hearing from the people that I'm working with, and I kind of want to tear my hair out. So I'm really
Don't do
glad to
that.
be.
So we actually, that's why we cut the myth busting in two, right? We already have a diagnosis myth busting that is out that you can listen to. So we had to separate the fertility part because there were just too many myths to bust, really.
Mhm. Yep.
And this time we are very lucky because we are going to have a buzzer. Woohoo! So watch out for the buzzer for what's true or false, what's a myth or a reality. And if you're ready, Nicola, we're going to start.
I am ready.
Okay, myth number 1. You've permanently damaged your ovaries.
Like, oh my God, no. I mean, it's absolutely a ridiculous thing for a doctor to say to a patient. First of all, hypothalamic amenorrhea really doesn't have much to do with your ovaries at all. It's about your hypothalamus being shut down, as you can learn about in, I think, episode 1 or 2. And it's, you know, it's it's really the case that none of us is actually broken with amenorrhea. Our system is simply suppressed, which is what totally makes sense biologically from an evolutionary perspective.
Yeah.
If you think about it from, you know, obviously there have been times in our species history where we've gone through, periods of famine, and it makes perfect sense for our bodies to shut down and not be able to produce offspring if there's a time when there's not a lot of available nutrients to feed such offspring. Um, And then it also makes perfect sense that once nutrients are more plentiful, that then the body turns back on again, and that's exactly
Yeah.
what happens with HA. So the idea that you've permanently broken your brain or your ovaries is just not backed up by any kind of fact at all. It's total myth. I want another buzzer there for that.
um, and the thing that's I find really silly is that it just brings so much fear in
Mhm.
patients, right? And I think if any doctors here are listening to us, it would be nice to just say that maybe you don't know enough and you would have to check and come back to the patient rather than saying like such dramatic statements.
Yes.
And I
Yes.
know we've spoken about bedside manners. Yeah, we've talked
Mhm.
about bedside manners or, being tactful as a doctor with Shanta also, and how she's had like terrible mentions from doctors about how she was completely broken, she would never have a kid or anything. She actually has a beautiful baby now, and it's just useless. It's just like
Yes.
I don't get it. If you don't know, just say that you don't know, or just politely say that you will come back with some answers later. And definitely, yeah, I love that you said your ovaries are actually not in your brain, or your hypothalamus is also not in your ovaries. That's a good point. I will go and review some of my anatomy knowledge here. Um, okay, myth number 2: only 2% of HA patients can actually recover.
Okay, this kind of goes along with the previous myth, and this is also a big fat no. So, as part of the survey that I did for the book No Period, Now What, I did ask this question, and I sort of followed up with a lot of people after they were recovered. Did because some people use fertility treatments to get pregnant. So, then there's pregnancy and breastfeeding, which both suppress ovulation and periods. So I followed up and I found that of the people that I could get data on, the recovery rate was about 98%. So that's very different from 2%. And again, is why I say we're not broken, we're just suppressed, shut down in a way that makes biological sense. So I know very few people since then that have not been able to restart cycles. Some people take a longer time. Some people need a push from, other medications or what have you. But, overall, the recovery rate from this is excellent because, again, it's a natural biological function to suppress your system when you're not getting enough fuel or you're generating other suppressive signals to your hypothalamus like cortisol from high intensity exercise. So it makes perfect sense that your hypothalamus is shut down and also that it can restart and you can get cycles again. And I was actually just chatting with a new client yesterday who has primary amenorrhea. So I want to keep mentioning that as well, that if you have primary amenorrhea because of underfueling and overexercise that started when you were quite young, that can mean you don't get your first period, but it doesn't mean that you can't start it later on in life. So I've had women in their early 30s who have had their very first period of their entire life after working with me on, properly fueling and, cutting exercise and working with you on the body image stuff. And, you know, so again, it's the recovery rate from this condition is excellent, and it's a matter of doing those lifestyle changes, having some patience, which is hard for us type
Yeah,
A personalities,
yeah.
but it's definitely part of the equation as well. So I think this is another like big fat no. The chances of recovery are really good. Chances of pregnancy are really good. So like myth busted, totally.
Beautiful. And I think that's something I use a lot with my clients when they get impatient. I always say, like, it's a matter of when, not if. So,
Hmm.
so just kind
Yep.
of keep that little hope, because it is hard when you're in the thick of recovery. It's really hard to just kind of think that it's only a week, it's only another month, it's only, it feels like forever, right?
Yes.
But
Yes.
but retrospectively, you can see like it usually, the average, the median we usually say is 6 months. I know for some it happens really fast. For others, it will take, maybe closer to a year. But it's definitely something that I've never seen anybody regret. And I think
Yeah.
holding on to the 98% success rate is really, really helpful in recovery, and feeling like I'm going to do this. I'm going to take my time. Maybe it's the first time I have to be patient, right? Because
Yeah, I mean, I think so. There are a couple of other things that I wanted to say that from what you brought up. So, one is that I know that a lot of people are in our support group, and that when you're somebody who is taking a little bit longer to get your period back, it can be really hard to see, like, a new person comes into the group and 4 weeks later, "Oh my god, I got my first period," like, "Yay." And, I think for people who have taken longer than that, that can be really hard.
yeah,
So I think, again, the point about not comparing to other people is so important because we
super
all
important.
have different journeys, different ways that we got our HA in the first place, different journeys to get out of it. Some people go all in right away, and that does tend to lead to quicker recovery. Some people, it's just not mentally possible, and they need to do some other work before they're ready to go all in. And, you know, that's okay. Like, everybody's journey is different. And so I think that that's, trying not to compare yourself to other people is really important. Um, Another thing is the 98% statistic. It could actually be higher than that. I just lost touch with a couple of people, so I had to assume, to be correct statistically, that they did not get their periods back, but I don't actually know that for a fact. So, even if you think you might be in that 2%, like, it might be 0%. I mean, who knows? But there, it's just like, the point is that the chances of recovery are really, really, really high, and it's just a matter of making these changes and being consistent with them, and getting support where you need to in order to remain consistent, and basically make this your new life going forward.
Totally. And I love the no comparison idea, because I think it helps a lot with body image in general as
Mhm.
well. Just being able to stop the comparison, on social media, or constantly thinking, oh, my friend posted this, so I should post that. And maybe, if I am XYZ different, then I'm gonna attract more attention. It's really this idea of saying, like, I'm just following my own path, right?
Yes.
So it's a good exercise, actually, not just for patients in recovery, but in general, also about how we compare our appearance to usually everybody else. And that's the other thing.
Yes.
Like, we tend to compare to people that are not really comparable. Like, I cannot compare myself to Jennifer Lopez, right?
Yeah. For me, it was Natalie
She
Portman.
But there you go. There you go.
Yeah.
I don't know, they're like 45, 50 years old. They look much younger than that. They just, I keep seeing that stuff about, oh, look at Jennifer Lopez. And I'm like, how much money is she throwing at this? You know what I mean?
Yeah.
Like,
Yep.
how much support does she have? And yes, she had twins, but is she even raising them? Like,
Oh.
you know, you, you don't know. We don't know. And I think
Yep.
that's a big, it's not a judgment towards anybody else. I'm just saying, we don't know. We just have to
Mhm.
agree that whatever we see on social media, we don't actually know what's behind that. And
Right.
that's going back to the disordered eating, is that a lot of the images that we see, we don't know what the people posting them actually go through.
Mhm. Yeah.
So having that kind of staying in our lane is definitely a good exercise to keep in recovery.
Yes.
Um, okay, let's do myth number 3. If you want to get pregnant, you will have to use fertility treatments.
Nope, that's not true. I like the buzzer. We might
We
just
love
have to
the
do it
buzzer.
ourselves. Yes. Um, so again, this is a statement made by some medical professionals who do not truly understand hypothalamic amenorrhea. They don't understand that it's a temporary suppression of your hypothalamus, and therefore suppression of your reproductive system. And so they will often say, oh, just go on the pill. And then when you want to get pregnant, come and see me and we'll do fertility treatments. So if you don't do anything to work on your amenorrhea, in terms of you make no lifestyle changes, then yeah, you're going to need fertility treatments to get pregnant.
Mhm.
I mean, that's, you can't get pregnant if you're not ovulating, and if you're not getting a period, you're not ovulating. So that much is true. But the idea that you can't make changes to then get pregnant naturally, or, using other less invasive fertility treatments is just not the case. It's
Mhm.
total myth again.
That's really important, that there's definitely a way out of this. And as you always say, there's different ways out of HA. So for some of us, it might require a bit of an extra support if we want to have a baby, or depending on what's our timeline. But there's definitely also many different ways to try and work on conceiving a child naturally,
Yep. Yes.
which can be a beautiful process as well. I think if you manage to.
Yeah, I mean, as we've discussed before, recovery is about so much more than just getting your period. It's
Mhm.
about enjoying your life more and not focusing all the time on your food and your exercise, and that to the exclusion of relationships in your life. And, so many people find that their life feels so much more free and open and lovely once they've gone through the process of recovery, because
Mhm.
it's you realize that you don't actually have to control every morsel that goes into your mouth. You can enjoy a piece of cake for a friend's birthday and not think twice about it. And you don't have to exercise every single day in order to be fit and strong and healthy. And like all of that just means it opens up so many vistas in your life that were unavailable to you when that was all you could think about. So, big
I
plug
love
for
it.
the mental side of recovery as well as the physical side.
Totally. Where do I sign, Nicola? You've got me convinced.
Yes.
Now, what I always find amazing is that after a few sessions, maybe it's going to be, I don't know, a couple of months of hard work, you start to see different symptoms happening. Maybe you're going to start seeing cervical mucus, maybe you're going to, but a lot of the people I work with, they end up saying, I'm so much more joyful. I'm
Mhm.
actually laughing again.
Yes.
And, I have this wide range of emotions that I didn't have anymore. So it also means that you might experience also, moments where you're maybe a little bit sad, and definitely hormones are also
Mhm.
related to that. But
Yep.
I love that, they kind of come back to life also on the emotional level, where they said before everything was kind of bland, right?
Yeah.
Everything was the same. Because I was in the routine so much, I was not really connecting with anybody on any level. I wasn't doing it because I loved it. It was more because I had to do it. Otherwise, I experienced huge amounts of guilt or fear, or whatever it was going to be. And now I can actually connect with lots of joyful things as well. And I
Mhm.
realized that I can actually laugh with my partner, or we can be silly together. And so
Mhm.
that's definitely a good point for recovery as well. Great. Number 4, there is no point to go all in if you are going to do fertility treatments anyway.
Another big fat to that one. Um, so, you know, yes, there are people who can continue to maintain an HA lifestyle in terms of restricting and exercising every day and use fertility treatments to get pregnant. That is undeniable. It happens. However, the success rates for fertility treatments in that group of people is undeniably lower than the success rate in people who have gone all in and are working on recovery and properly fueling their body and, cutting out the high intensity exercise. So there are a couple of reasons for that. One is that some of the fertility treatments require a working hypothalamus. So the oral medications like Clomid and Femara, for example, they just give your body a push to start a natural menstrual cycle. So it's,
Mhm.
they lower the estradiol level, which pushes your hypothalamus to send out more gonadotropin releasing hormone, which then goes to your pituitary, makes follicle stimulating hormone, which goes to your ovaries and starts the follicular growth process. So those medications don't work if you are still in the midst of HA. Um, Beyond that, the gonadotropin pump, which is available I know it's available in France and Canada. I'm not sure about anywhere else. It's definitely not available in the US unless you're in a clinical trial. That sort of takes over the role of the hypothalamus. As do the FSH and LH injections, or obviously if you're doing IVF. The hypothalamus is out of the picture in those cases. But that doesn't mean that your body is necessarily ready for pregnancy. So there was a study that I found and talk about in the book, where leptin is actually highly involved in the process of implantation. And so if your leptin levels are low for what your body needs, it might be that you have, that an embryo that is created has a harder time implanting. There are also a lot in people who are still in that HA mindset and lifestyle. There are typically more issues with fertility cycles. So, injectable cycles where they're super long, it takes a long time for a follicle to start growing, or you overstimulate and, have to cancel the cycle. And I think that's part of that is because your body just has a harder time regulating the follicular growth process when your natural hormones are sort of out of whack, as different, not where they should be. um, and IVF, I've worked with many people who've had multiple failed IVF cycles, 4, 5, 6, and then worked with me on making the HA, making lifestyle changes, and then gone on to get pregnant either naturally with oral medications or had a
Wow.
frozen embryo cycle planned already that has then been successful when they've not been successful in the past. So, from my experience, going all in, even if you're planning on doing fertility treatments, is so worth it because it just increases the chances of getting pregnant, as well as having a healthy pregnancy. And, you know, uh, I often see people who haven't really done the mental work towards their own body and body image before pregnancy really, really struggling with
Yeah.
being pregnant and gaining enough weight. And so it's a much harder process. The pregnancy itself is harder on you if you haven't done any of this work before you get pregnant. And it's
Mhm.
sort of like there's that ideal pregnant woman, like the little bowling ball in front of your belly is the only way that you show as
Oh
being pregnant.
God.
And it's like, when that's not healthy. It's not good for you or your baby to be so focused on your body when you're pregnant. And so I think going all in and working on the mental aspect before pregnancy is, it's just so helpful. So, both for the reasons of having an easier time getting pregnant and having an easier time with pregnancy, all in before you get pregnant or before you're trying to get pregnant is so beneficial.
Well, that was really interesting because I didn't know about all of those different aspects. So thank you so much for that. I was lucky not to have to go through fertility treatment. And it was actually not very accessible for me as well,
Mhm.
because it would have been crazy expensive. And at the time I would have done that, it was not even allowed in Dubai. So it was extra complicated. But I think it's really important what you mentioned about, the role of the hypothalamus, even in treatment, right, is
Mhm.
key. The leptin being overstimulated also, like it's terribly painful. Like those are really invasive procedures that, I know every person that I know that has been through that, like really remembers this as being
Mhm.
extremely difficult to live through. So I think it's totally worth giving it a try. And you're totally right. Obviously, unfortunately, we know that lots of people getting pregnant can still suffer from disordered eating or eating
Mhm.
disorders. And
Absolutely.
there is that hyper focus from the medical industry as well, in my mind, on how much weight you gain during pregnancy. And I totally agree with you that I think if you've done the work, being all in, kind of trying to dissociate your worth from your weight, it's going to be a lot easier to kind of keep your head on your shoulders when your doctor might be freaking out, and there's really no reason to freak out. Because that's the other thing that I found is like, I don't know if that's true. Maybe you'll have to correct that. Maybe we'll have to edit that out. But I remember that I was told that if you start your pregnancy at a kind of lower end of your set point weight, then you might need to actually gain a lot more for your pregnancy to be healthy. And I think this is something that doctors don't really take into consideration as well. They kind of see you coming, this is your pre-pregnancy weight, this is how much you should take, you should put on,
Mhm.
and that's
Mhm.
that. But the
Yeah.
reality is, if you come from literally HA is starvation, right?
Mhm.
Starvation
Mhm.
level. Then for you to sustain a pregnancy and be well, uh, physically and mentally as well, because come on, pregnancy and postpartum like is tough on us mentally.
Yes.
um,
Yes.
you definitely want to like gain as much as you need to. And
Mhm.
I wish a lot of doctors would also take that into consideration, because my doctor, even though she knew I had just recovered from HA, not by her help, by the way,
Mhm.
just because of you,
Mhm.
Nicola. I literally showed up one day in her office and I was pregnant, and she was like, how? What? So she did nothing for it, saw me coming pregnant, and she was still freaking out like every time I used to gain a little bit more. And you know how
Mhm.
it is, like some months you feel like you kind of gain like a lot, and then the next month you might not gain that much. And so the fact that she would freak out every time, if you don't do any of that mental work, it's very, very stressful also to go through that. So
And I think it's important too to note that a lot of doctors freak out a lot more if you're gaining quote unquote too much than if you're gaining not quite
not
enough. And
enough.
I mean,
Exactly.
it's there's actually a book called Expecting Better by Emily Oster that
Hmm.
has a pretty good literature review of the literature on sort of quote unquote overgaining versus quote unquote undergaining, whatever. I
We
mean,
love those
the
words, right?
idea, what worries me when people are gaining not enough in terms of, the baby weighs a certain amount, the placenta, the amniotic fluid, the uterus expands an enormous amount. So that muscle is gaining weight. You gain blood volume, you gain, your breasts grow. So there is an amount of weight that is simply related to the pregnancy.
Yeah.
And if you're not gaining at least that, then you yourself are losing weight. And there's doesn't seem to be a recognition of that in a lot of doctors, and they will look at they will say, oh, you're probably not gaining enough, let's check the baby. The baby is typically fine, sometimes a bit
Yeah.
underweight, but generally the baby will get what they need even if they have to fight harder for it. But there's no recognition of the consequences for the mom
Yeah.
postpartum of having lost weight during pregnancy and being
Yeah.
even further underweight after giving birth. And that can
Totally.
cause issues with breastfeeding. And most of all, it can cause mental issues. It can be,
Yeah.
because you're starving and trying to provide for your baby at the same time. And so I think that's a place where I really, really wish that doctors would focus a little bit more on the mother and what's going on with her rather than simply focusing on, oh, the baby's fine, it's not a problem that you've only gained X amount that's less than all those pregnancy components add up to. So,
That is so important. I'm so glad that you said that. You're so right, because I think we don't equip mothers, and even just in terms of information, there's not a lot of information about what it means to be postpartum,
mhm,
and how hard it can be. right? You have this kind of huge changes in your body, and nobody really, I mean, I find that it's only now that we start seeing more people online also kind of sharing this is really what postpartum is. But and you're right, we cannot just put ahead the health of a child. If the mom is unwell, then definitely the child is going to suffer at some point.
Yeah.
And babies, obviously, all they want, all they need is being fed, being held. But we know that babies sense very early on the stress levels of their parents, right? I read this fascinating book on ADHD, for example, by Gabor Mate. Gabor Mate is this amazing guy who's like not only a psychiatrist, he's also a gynecologist, like one of these kind of multi-talented people, right? And
Mhm.
he was saying like that from very early on, kids can totally notice what's going on, and if you're off, even just mentally, right? Even if
Mm.
physically you're okay, but mentally you feel you struggle. So I think that's major point. It's not just about baby's health, it's also about your health. And trying to breastfeed, being on top of just taking care of yourself, getting enough rest with a newborn and all of that, you really don't have to also worry about how much you're allowed to eat, or
Mm.
how to gain. Like, it's really difficult to gain when you're breastfeeding. If you have the chance to breastfeed, like, you need to eat like even more.
Yeah.
So getting rid of the rules and the quantities and what you're allowed and what you're not allowed and at what time and all of this, it's really freeing, because you're
Yeah.
effectively up at any hour and you need as much energy as you can, literally.
Mhm.
So
Yep.
that's super important. Okay, number 5, you need to thicken your lining, quote unquote, before fertility treatments.
Um, so myth, I don't really know where this idea comes from, but I wanted to put it in here because it's something that has come up a few times. People saying, "Oh, I have to take estrogen and progesterone before I even start my fertility treatment cycle to thicken my lining." And I don't really understand why that is because, again, hypothalamic amenorrhea doesn't mean you're broken, it just means your system is suppressed. So as soon as your uterus starts seeing the estrogen from a growing follicle, your lining thickens. So this like pre-treatment idea just I don't really get it. I've worked with many women who have had successful fertility treatments, whether it be oral medications or injections or IVF, without doing this pre-treatment thickening your lining thing. So yeah, I just don't know what the evidence is for that, or I don't believe there is any evidence actually.
Yeah.
It's
I mean,
just
you
a thing
kind
that's
of
out there,
wonder.
and yeah.
Yeah. And you kind of wonder sometimes, right? I mean, in Western medicine, how much of the pharmaceuticals also play a role, right? I don't know. I mean, it's just one of those questions. Like, do they just sell more of the whatever,
Who knows?
meds to, yeah, you kind of hormone replacement. I don't know. Like, are they told you really
Yeah,
need to do this before? It's just impossible to know. I mean, I'm not a doctor.
yeah.
But yeah, it sounds, and I think it goes back to what you said in episode 2 about the basics of HA in terms of this overvaluation of the role of estrogen, and
Mhm.
saying that the key is not so much the estrogen that's kind of flowing from an ovulation and a proper cycle. The problem is really before that, right?
Yes.
It's
Yeah.
really, how do we create enough a good environment for the ovulation to take place, and that's why we typically more look at LH, FSH rather than estrogen and progesterone.
Yes.
So that's
Yep.
that's kind of, to me, it goes back to that. Okay. Myth number 6: Provera or birth control pills will jumpstart your cycles. That's one of my favorite.
So, again, another big fat no to this one. I've been thinking about it a lot because it's something that comes up a lot, and I'm sort of like, where does this idea come from? Because sort of the idea of providing your body again with small amounts of the downstream hormones. So these are hormones that are
Hmm.
produced by your ovaries. They don't they don't do anything to create ovulation. If you take estrogen, you're not going to ovulate because it actually suppresses your FSH and LH. So I've been trying to figure out why so many doctors say this to patients. And the only thing I could come up with is that because the Provera or birth control pills do suppress FSH and LH, when you stop, then the FSH and LH will rebound a little bit. So perhaps there is this idea that the rebound could then cause, your follicle to start growing and cause you to ovulate. But that just doesn't happen in practice. I can't think of anybody that actually gotten a cycle back simply from doing a cycle of birth control pills or Provera. Um, especially if they're still, engaged in an HA like lifestyle. So while FSH and LH do bump up a little bit, it's not sustained and it doesn't get high enough to
Hmm.
actually grow a follicle. So that's another myth that's, it's something that people are often told. So Clomid and Femara are medications that can jumpstart your hypothalamus. So that's a little bit of a different situation. But it's because they push your hypothalamus to get started versus the estrogen and progesterone, which again are downstream hormones, don't really have the same effect of getting a sustained increase in FSH to push your ovaries to then start the follicular growth process.
Yeah, I'm probably going to edit that out, but I think we need a metaphor for this for people to understand. You know what I mean?
So I do have a
You
blog
have
post
one?
on this. Yeah, it's at noperiod.info/progesterone. So the way I kind of think about it is if you think about your reproductive system as a reservoir, and when you have HA, the reservoir, the reservoir is dammed, it's blocked. And estrogen and progesterone are kind of like the river that flows out of the reservoir. So
Yep.
if you go with, if you go to a reservoir with a hose and you put the hose downstream of the reservoir, yes, you have water coming out, but it's not the normal flow. It's not the normal river that's supposed to happen. So you need to release the dam, and releasing that dam is getting your hypothalamus to start back up again. So you don't need a hose downstream. You need to fill up the reservoir and open it up, and that's how you get your system started again.
See, you had it already. I love it. Great. I love metaphors. I think it's so much easier to understand. If
Mhm. Mhm.
that's actually we had Dr. Gordiani on, and she uses a lot of those, right? And it's
Yep.
so helpful in recovery to kind of compare it and use imagery that makes it really simple to understand. So thank you for that.
Absolutely.
Um, Myth number 7, low AMH means you're going to have trouble getting pregnant.
So this one is a bit of a challenge. So AMH is anti-Müllerian hormone. It's something that was discovered somewhat recently, and when you consider all of fertility treatment history, and there seems to be an association between low AMH and ovarian reserve. Such that somebody that has AMH that's lower than the normal range for their age might be headed toward an earlier menopause, or might have some trouble with getting pregnant because they don't have enough eggs, or it can be associated
Okay.
maybe with egg quality. The problem is that there haven't been good population-wide studies of what AMH looks like. So a lot of the information that we have about AMH comes from people who are already undergoing fertility treatments, which means that there can be a correlation, but it's not necessarily causative, and it doesn't have sort of it's not a definitive number. Like, you can't say your AMH is zero point 0.5, there's no way you can get pregnant. And another thing is there was some research that I cover in the book, that found that AMH levels are correlated with LH levels. So if that's the case, you might expect that it's not unreasonable to think that somebody with low LH because they have HA also might have a low AMH level. And in fact, I have seen people through recovery with their AMH levels going up. Um, so this is another sort of bedside manner issue as well, in that if somebody has low AMH, they can be told, "Oh, you have premature ovarian failure and you're not going to be able to get pregnant," or "Oh, you have diminished ovarian reserve, you're not going to be able to get pregnant." And it's like I would just love for the conversation to be a little bit more nuanced. And, there's some suggestions that maybe pregnancy might be more difficult. So maybe if you're in your mid 30s, you might consider doing fertility treatments sooner rather than later. But it's not the case that, simply that one number is,
Hmm.
defining everything about you and everything about your process to get pregnant or your ability to get pregnant or anything like that. So I really just caution people to not take that number as a be all end all. And, it's definitely much more fluid than the picture that is often painted by the medical professionals. So I just love for the conversation to be a bit more nuanced than it often is.
Yeah, because also if you think about it, like this is such a really, I mean, such a difficult statement to make to a person that's trying to actually conceive a baby, to say like, you're actually, you might never have a child. Your body is kind of incapable of having a child ever, and you're like in premenopause. It's really violent to say
Yeah,
this. So
it
to
is.
me, like again, like if you are gonna say this, you gotta be pretty sure of what you're saying here before you're gonna announce that to anybody, because
Mhm.
what a heartbreak.
Yeah,
And as you said, like if there's not enough research, why are we even bringing that up to light as this definitive measure?
yeah.
So super important. And I think the next myth is also about AMH.
Mhm.
The next one was saying high AMH means you have PCOS.
So again, this one's a little bit more nuanced as well. So high AMH can be associated with PCOS, but it is not part of the diagnostic criteria. And for sure, you can also have high AMH if you have HA. So it's actually really interesting because I've seen such a wide range of AMH levels in people that have HA, from quite low, as in, zero point 0.4, zero point 0.5, all the way up to 14 or 15. So it really runs the gamut. So again, it's it's somewhat related to the number of follicles, the number of antral follicles that you have on your ovaries, which is small follicles that are between sort of 2 to 9 millimeters, resting follicles, pre-ovulatory. You can call them any of those things. Also called cysts, quote unquote, and that's where the
Oh,
polycystic ovarian comes from. Is they call these follicles, resting follicles, they're called cysts. Not really sure why that is. It's sort of an anachronism. Um, so if you have a lot of resting follicles, your AMH is often quite high. And we know that somebody with HA can have a lot of resting follicles. Their ovaries are multicystic as opposed to polycystic. And the difference can be quite small. So polycystic ovaries require, the definition that is um, sort of most supported by research is that you have 25 or more follicles on one ovary, or an ovarian volume of 10 cubic centimeters, 10 milliliters or greater. Somebody with HA might have 20 follicles per ovary. And physician can't just look at the scan and be like, oh, it's polycystic. You have to actually count the
yeah.
ovary, count the follicles. Um, and also look at blood work, because again, the two conditions can manifest quite similarly, as we discussed with Julie Duffy Dillon on episode 5, I believe. So did you have something else you wanted to say, Florence?
I think it's really interesting that you've seen such a wide range of results amongst the population that you typically work with, which is in HA.
Mhm.
So I think, can we say that it would be better to maybe ignore AMH completely?
I mean, I don't find that it has much value for this
Okay.
patient population. I mean, I don't know enough to say about, people who have infertility for other reasons, but certainly in
No, of
somebody with
course, of course.
HA, as I said, the range is enormous. So I just don't think that I think that that would probably be a good approach is just not to, certainly not putting very much weight on that number, whatever it is.
Yeah. So
So
keeping it aside and just kind of not really paying too much attention to it,
yeah,
even if your doctor says it's super important or says anything.
yeah.
And I know you have a blog post about that as well, don't you?
Yes, so there's it's noperiod.info/HAVS 2,
Yeah.
and that sort of talks about how in HA recovery, um, some of your androgens can go higher than normal, and it also talks about the AMH and lack of association with, basically with much of anything when you have HA. So
Yeah.
that would be
We
a good,
don't really
yeah.
we don't really need you, AMH. Bye.
Yeah. I mean, as I said, if you're sort of thinking about doing fertility treatments, and your AMH is low, then, maybe you consider moving forward a little bit more quickly than you would otherwise. But I think that's really the only thing
Mhm.
that I would sort of suggest using it for.
Okay, great. And then we have myth number 9: Clomid and Femara won't work because you have HA.
So this is another one that's sort of nuanced, somewhat true, somewhat not true. So, yes, if somebody, as we discussed at the beginning of the episode, if somebody is still fully in HA like behaviors, then Clomid and Femara won't work because their hypothalamus is not in a position to really do anything. And those two medications do require a working, non suppressed hypothalamus. But doctors often say that to somebody who's had HA and been working on recovery. And in that case, it's not true. So big there. If you've been working on recovery, then often, your hypothalamus kind of recovers and becomes desuppressed. And the last thing to come back is that signal to start the follicular growth process. And that is what Clomid and Femara do. So they
Okay.
absolutely do work in somebody who's been working on recovery. And from my perspective, they're a much better choice for ovulation induction than injections, which are much harder to control, more likely to have multiple follicles, and then, multiple pregnancy. And then you have to consider, maybe termination or pregnancy reduction. And it's, we have a friend who got pregnant with 6 babies, like from an injectable
Yeah.
cycle. You don't have to worry about that with the oral medications. So, I just generally encourage people to work on recovery and think about the oral medications before sort of stepping into some of the higher level fertility treatments. And I do discuss all of this in No Period Now What. So there's a whole section on getting pregnant. That we talk about, sort of tracking your ovulation so you can get pregnant naturally after you've started cycling again, or get pregnant on your very first ovulation, because that happens too. And then all about all the different levels of fertility treatments, so the oral medications, injections,
Yeah.
IVF, sort of things to look out for in each of those situations. um, so yeah, plug for that
And
section
you
for those who are getting looking to get pregnant.
Yeah, really important. And you also support people working on recovery while going through fertility treatment. So that's also super important, is that you have a really specific knowledge of what it means if someone, for some reason, there's plenty of reasons, cannot wait or does want to go ahead with fertility treatments, is also working on recovery naturally, but wants to have some advice. I think that would be invaluable to actually get your support, because I think sometimes you really have to advocate for
Mm,
yourself at your reproductive endocrinologist's office. And for a lot of countries, actually, the function of RE doesn't even exist in many
mhm,
places. So you
mhm.
do get the support of a fertility doctor, but it might not be someone who's really versed in hormonal situations. So I think, having your support in those cases sounds really sane to me.
And I can spend
Um,
I can spend a lot more time with people than their doctors often can, so answer
oh,
questions
yeah.
that
Oh,
come up.
God.
And I think I'm a little less intimidating sometimes.
I don't think you're intimidating at all. I hate to break it to you.
I have had a few clients be like, "I'm so nervous to talk to you." I'm like, "I'm just
But
me."
Definitely. Yeah. If you're scared, just give it a try. Like she hasn't bitten anybody that we know of. Uh, so no, she's lovely. Give her a go. Okay. And last myth on our list for today, number 10, if you don't respond to stimulations within X days, it will not work. So fertility treatments would not work.
So eh, this is a tricky one too, because it is important if you. So I think this is mostly involving injection cycles,
Yeah.
because that's the place where we've seen this come up. So with injection cycles, you kind of want to start with a low dose because often, as we were just discussing, people with HA have a large number of follicles. And so if you go right in with a big dose, then you get a lot of follicles to mature and you're either canceling the cycle or getting pregnant with six babies, neither of which is ideal. Um, so the tendency is to go more slowly. And so, it really depends on your doctor's experience with HA and how as to how quickly they will increase the dosage. But I've seen some people go really, really slowly on increasing the dosage of FSH and LH, and so it's start with 37.5 international units, and maybe you bump up to like 45, and so it can go very slowly. And some doctors are unwilling to do that more than increase the dose more than once a week or more than once every 2 weeks. So, I mean, I've seen people with cycles that are 45, 50 days long, but they
Wow.
do eventually respond. I mean, it kind of stinks, and I think that really, that's why I recommend oral medications instead of the
Yeah.
injectable. Like I said, just so many parameters to work with in terms of the injections and how an individual is going to respond. In general, people will respond eventually when the dosage of FSH is right for their body. So
Mhm.
canceling a cycle after, certainly after just a few days doesn't make sense. If you've only been on injections for, 3 or 4 days and, you're not seeing anything, well, bump the dose up a little bit. I do recommend bumping it up on the slower side rather than, I wouldn't
Yeah.
double the dose typically. I mean, 37.5 to 75 is typically fine, but 75 to 150 is often where problems happen in terms of overstimulation. So kind of maybe going up by increments of 37.5, which is half a vial. That's why it's such a strange number. Of a vial of Menopur or FSH or whatever is typically 75 units. So half of that is 37.5. That's where the number comes from. But so just, not going up too fast, but also not waiting an inordinate amount of time before increasing the dose, I think is, the general path forward. But again, this is where, it's really something that you have to work very closely with your reproductive endocrinologist on. But just hopefully somebody who's willing to increase a little bit faster so that you're not taking 45 or 50 days of
Yeah.
injections to actually get a chance to get pregnant. Um,
Makes sense.
so yeah.
Great. Well, that was like packed with information. So I'm so glad we did this. And there are actually so many points and comments and arguments that are just completely untrue, right? It's a bit nuts to think that there
Yes,
is
it
a lot of
is.
misinformation, I guess.
Mhm. Yeah, and
Um,
I think part of it just stems from the fact that HA is one of the less common fertility
yeah,
issues. So I think that a lot of doctors just aren't necessarily aware of it in the first place or aren't aware of the nuances around it because it's not something that they see that often. So, it kind of makes sense from that perspective. Um,
totally.
but I just, I would love to get a little bit more education out there. And I think that this is a place where educating ourselves as patients so that we can speak to the doctors, about the different issues and have an understanding of the physiology behind why things are happening, I think is really, really important.
Totally. And I mean, I'm probably speaking for all the listeners and how grateful we are that you also took a big chunk of the book to talk about these different possibilities, right? There's not just a book about recovering naturally, but it's not just a book about getting periods back. It's also a book about fertility, about enhancing your natural fertility, or understanding when you ovulate, or, making sure that you ovulate. I find it amazing that you shared so much of your knowledge. And I find amazing that we don't teach us that in school, to be honest.
Mhm.
Maybe not the fertility treatments, right? But
Yeah.
some sort of basic information about how our cycles work. And I'm so grateful that it's actually available so easily. So thank you very much for that. I know it's
Absolutely. Thank
a lot
you.
of work, to put all of this together for us to actually enjoy, and really changing so many lives, right? Not just the mothers, but creating many lives as well.
Yeah.
So it's really
Yes.
cool.
Yes.
Have you ever counted actually how many babies have
Oh gosh.
been
I mean,
born under your
um,
guidance?
I mean, it was around 500 when I wrote the book, so that was 4 years, 5 gosh, almost 5 years ago now, and the pregnancy groups have about 250 people per year, so that's, another couple, maybe up to another couple thousand at this point, because people who got pregnant 2 years ago are now getting pregnant with their 2nd child, and so, yeah,
True.
it's kind of
True. I
cool.
mean, in my little group from the forum at the time, like, we've had many babies. Most of
Mhm,
us had more than one, and one of us had five, which is
mhm.
like incredible, if you think about it. So if you're in the midst of recovery and think like, I'm never going to get pregnant, I know I've said those things too, and my husband can
Mhm.
testify to that,
Yeah.
like,
Yeah, I
uh,
felt the same way. It's yeah.
and then, that 10 years down the line, some of us have five. So if
Mhm.
that's your dream, like, don't give up. You can do
Yeah.
this.
Um,
Okay,
so what
so
one other thing that I wanted to comment on before we go to our ending question is just that there's no shame in needing fertility treatments or wanting to do fertility treatments, and I think that sometimes that can be, it can be really hard for somebody if they would if they're trying to get pregnant and are not able to do it naturally for whatever reason. I mean, sometimes it's
yeah,
not ovulating as an HA, sometimes it can be issues with the partner, there can be other reasons for not being able to get pregnant. And I just want to say that you know, it's not something that you should be ashamed about. It's just, it's something that happens to some people, and it's nothing about you as a person or any failing on your part. And I think, I think often there's so many like fertility diets and everything that make people feel like, oh my God, what have I done wrong to, to get into this position? And just kind of taking some of that pressure off it. If you're having problems getting pregnant, it's not your fault. I mean, some of it, like the HA part, that's our society's problem, because that, we're pushed to be teeny tiny and
totally.
fit and all of that. So I blame society for that, even if, it's choices that we've made. But, fertility problems beyond that, like it's often nothing that we can control. And so I think just kind of realizing that it's okay if you do end up needing fertility treatments to get pregnant. There's nothing wrong with that. My 3rd baby is actually from IVF, because we tried naturally for a year and didn't get pregnant. And I have no shame about that. My kids actually all know that he was IVF, and he was made in a test tube, and the other two were made the good old fashioned way. And so I think it's important to take the stigma out of fertility treatments. There's nothing wrong with needing a little bit of help
Totally,
to get
totally.
pregnant.
And I think it goes full circle with what you said in the beginning, saying like, you're not broken, you're just
Mhm,
suppressed.
mhm,
Whatever the reasons are that you might need treatment, whether it is fertility or other ways, that you might require medication or support. I think our bodies are fine just the way they are. And, for some of us, it might mean that they live with disability, or I take medication every day. I will have to
mhm,
take medication every day for the rest of my life because of some autoimmune conditions that I have. And I refuse to see that as a way for my body to fail me. My body is never failing me. It's always on my side. And I
mhm,
think this is really important. And I know with infertility how isolating and how lonely it can feel. And I
Yeah.
think for a lot of
Yes.
us women as well, it's always kind of, oh, is it your fault? Is it his fault? There's always
Mhm.
this blame. And you're so right. We just need to kind of recognize that none of us are broken in any way, shape, or form. Whatever happens, our
Yeah.
bodies are always on our sides. So that's a nice way to close that for sure.
Yes. Yep.
So the usual question at the end of the podcast is, how have you been all in this fortnight, Nicola?
So I am in a new relationship and it's exciting for many reasons. But I think the way that I'm all in this relationship that's different from before is I'm really standing up and advocating for myself. So I have this nasty habit of even if something that upsets me, I just kind of stuff it inside and don't talk about it because you know, I f I have a really hard time with confrontation, and, so I'm working really hard on changing that aspect of myself and standing up and saying when I feel like something isn't right or when I would like something to be different, and, it's been challenging, but it's really interesting because often my fears about the confrontation don't come to pass, and the
Oh,
conversations actually end up being much more productive and
yes.
feeling much better than I have sort of made them out to be in my head. So that's something that I'm discovering, and yeah, so that's my all in for this week. How about you?
I think it's a lovely growth, to be honest. It's a growth path to just say, really, I'm going to speak up,
Mhm.
even if it's super uncomfortable and it's not
Yep.
something I'm used to. And I agree with you. I think a lot of what we fear, or how horrible we might feel before we say those things, is mostly anticipation.
Okay.
But a lot of the times, actually, it doesn't get as bad as we had imagined. But sometimes it's still scary, and
Yeah.
there can be a lot at stakes.
Yeah.
But I think it's important, as you say, also, like, in a new relationship, it's even more important, I think, to start on a really solid base
Yeah.
of how it's going to go if I don't agree with things, and I'm going to say
Yep.
it.
Yeah.
Because the
And
more you stay in that zone where you just keep it in and you don't really share, the hardest it gets to
yeah.
actually open up, because then your partner might say at some point, hang on, but you never said anything. What's
Yeah.
happening suddenly?
Yep.
So,
And I just wanna say I've been trying this in other aspects of my life as well. So I had a conversation with
oh,
somebody else
good.
that was a hard conversation, and it actually went worse than I expected. But that was okay too. Like, I
Mhm.
still felt better that I had said something, even though, like, it was more confrontational and did not have a great outcome, but I still was glad that I had stepped up and said something. So,
Of course, of
yeah.
course. It makes me think of that book Untamed, right, by
Mhm.
Glennon Doyle.
Yes.
Really
Absolutely.
great book, where she talks about the importance of living by our values, even if it's going to end up putting us sometimes in more difficult
Mhm.
situations. How important it is to
Yes.
feel aligned with the way we want to live, really.
Absolutely.
So
I
that's
second the recommendation for that book. It was
Oh
great.
yeah, I love that book.
Yes.
Amazing book. Anyway, I am all in this fortnight, trying to reintroduce a bit of self care that seems to go
Mhm.
out the window as soon as I get overwhelmed by the amount of stuff I have to do. So I'm going to try and build in a little bit of mindfulness meditation time for myself every day. I used to be pretty good at doing it every day, and it really
Mhm.
helps me just feeling more at peace with life in general, being less reactive and more responsive to my
Yep.
children and my
Mhm.
partner and whatever situation I'm facing. But for some reason, every time I'm into a phase of my life where it's really overwhelming and I have so much to do, and, the whole pandemic, right? Dealing with
Yeah.
multitasking, working
Yep.
and having a child next to you, potentially more than one child, and fixing their food all the time. And
Mhm.
I mean, you just feel like by the time you're ready for some self care, you're just going to drop dead on your bed,
Yeah.
right?
But it's the
So,
time when you need the self-care the most, right?
totally. So I think I really need to kind of reintroduce that at some point in the day before I get too tired. Because if I
Yes.
try meditation at 10 p.m., I will sleep, which is lovely. It's a good way to self care as well. But that's not really the point.
Yeah,
So
yes.
that's what I'm going to try and work on
That
that I could
sounds
think
great.
about
Yeah.
this time. Yeah. Cool. Well, it was a lovely episode as
Yes.
usual.
Yes.
Thank you
I
so much for
Absolutely.
bringing all your knowledge.
This is really great. I really enjoy talking about this stuff and
Yeah,
hopefully opening some eyes and some minds. And
yeah.
yeah,
I'm sure. I'm sure this is of support to many of our listeners that might be maybe in the midst of treatment or considering it or not so sure, like this person said that but another person said the opposite. I think it's sometimes really difficult to find what's true or false.
yeah.
So thank you for listening, and we will see you in 2 weeks with another
Sounds good.
episode.
All right. Bye.
Bye.
All right. I hope you enjoyed this episode. Maybe take a few minutes to reflect on it and how you have been all in this past week. It always strikes me how different each person's all in journey is. As I often say, there are many paths to HA and many paths out of it. Your journey is unique.
That is so true. And if you need more support on your journey, you should definitely start with No Period Now What, which you can get at noperiod.info/book.
And Florence and I both work with people on different aspects of period recovery and so much more. So if you'd like more personal advice and attention, you can go to noperiod.info/appointments to schedule a time to speak with me on fixing the issues underlying your missing periods and figuring out what those issues are.
And I'm at beyondbodyimage.com to work with me on the deeper emotional issues and your body image. I also run a French Instagram account, aminore_fr. And obviously you can find Nicola at No Period Now What on Instagram. We also have joint clients, so you can access both our domains of expertise at the same time. If you enjoyed this podcast and found it helpful, please drop us a review to help more people find it.
Also, join the No Period Now What recovery support group at noperiod.info/support and let us know how All In is going for you.
All In is not just about period recovery, it's about getting your life back. See you in 2 weeks.
You were lost in Babylon till you got lost again. You were lost in Babylon. Now find yourself and then take all that you've learned about love and loss, pleasure and pain, and never get lost again.